Critical Thinking and Coding Tips for Chapter 5. Our first question. A patient came into the hospital with shortness of breath and fever. Pneumonia was seen on the chest x-ray and the patient was treated with IV antibiotics. 3 days into the stay, the patient fell and fractured his hip. An open reduction was done and internal fixation was placed. The patient was discharged to a rehabilitation facility. What is the principal diagnosis? Well, the answer is, the principal diagnosis is pneumonia. Even though the patient had a fracture and had a procedure to repair it, the hip fracture does not meet the definition of principal diagnosis. The definition of principal diagnosis is the condition established after study to be chiefly responsible for occasioning the admission of the patient to the hospital. Specifically, in this case, the pneumonia is chiefly responsible for the admission. The hip fracture occurred after the admission and was not the reason for the admission. It's impossible to keep the definition clear when coding to ensure its accurate assignment of the diagnosis. Our next question, are there always two codes necessary to accurately code acute and chronic conditions? And our answer, not necessarily. It depends on the instructions given in the alphabetic and tabular indexes of the ICD-9-CM codebook. Each category of codes classifies diagnoses differently. For instance, acute and chronic bronchitis indexes to two different codes, 466.0 and 490 respectively. However, acute and chronic respiratory failure indexes to one code, 518.84. Refer to the instructions in the alphabetic and tabular indexes and review the notes associated with the codes. It's imperative to also read the excludes notes, includes notes, omit codes, etc. When coding each and every code, do not assume that each diagnosis is classified the same way throughout the coding structure. And our final question. Urosepsis is one of the most misused words in physician documentation. ICD-9-CM classifies urosepsis as a urinary tract infection 599.0. However, often physicians who document urosepsis are referring to a urinary tract infection that has invaded the blood and leads to sepsis, not simply an infection of the urinary system. What should a coder do if urosepsis is documented in the medical record? And our answer is, review the MSDRG list. Refer to the UTI MSDRGs versus the sepsis septicemia MSDRGs. Notice the difference in relative weights and length of stay. Which seems more appropriate based on the hospital stay? Consider how a hospital can lose money if a patient is truly septic and only a UTI is coded. On the other hand, upcoding can fraudulently increase the reimbursement if sepsis is coded and the patient truly only had a UTI. Now multiply this by the number of patients who may have a diagnosis in a year. If there is any confusion related to the documentation and coding of urosepsis, it's important to query the physician. Now to go one step further, try to educate the physicians on the importance of not using the word urosepsis in their documentation by showing them significant differences in the coding structure.